Good afternoon, everyone. PCOE MCH Kolkata welcomes all the participants for today's RDLS session. Today's topic is DTG 10mg, Overview and Case-Based Learning, and the speaker is Dr. Amrita C. Dr. Amrita ma'am is a professor with the Department of Pharmacology at Medical College Kolkata, West Bengal. She has received numerous accolades, including MD in Pharmacology topper in 2012, Best Speaker at EZIPS 2012, UK State Award at IPSCon 2014, and the Bisnupriya Devi Award for the Best Original Article in IJDVL 2024, along with multiple scholarship and research awards. Her areas of interest include good clinical practice, medical ethics, research methodology, clinical trials, and medical education. Ma'am has authored 52 publications in PubMed Index journals and contributed to 8 book chapters, demonstrating her dedication to advancing medical knowledge. We welcome you, ma'am, for today's session and request you to start the session.
Thank you for your kind introduction, and very good afternoon to all the participants and all the health professionals who have dedicated themselves for taming HIV. I thank the organizers for inviting me to this RDLS session on dolutegravir 10 milligram, an overview and case-based learning. So without much ado, I would like to start with one slide showing that as more therapies grow, we as clinicians always look forward to give safe and effective therapy to our patients. Keeping this in mind, NACO on 14th of August 2023 had a memorandum and also guidelines where they proposed dolutegravir 10 milligram pediatric dosage in children living with HIV and who were of weight less than 20 kgs. So as we know, dolutegravir was also previously used for adult HIV patients, but now we have this dolutegravir dispersible tablets which are good in taste and are safe, effective, has very less adverse effects, and also has very less potential drug interactions, and they are harmonized to the adult schedule. So with this background, let us start the session objectives. When we go for anything new, we always want to understand and discuss what are the guidelines and how are the regimes that are to be given when dolutegravir 10 milligram is incorporated. So we will be discussing about the first line ART regimes in ART naive children who weigh less than 20 milligram, and also for those children who are less than 20 milligram, but they are on different schedule, how to transition them to dolutegravir 10 milligram. Then we'll be talking about the TB and HIV co-infected children, how the dolutegravir prescribing will be modified. And then I'll be taking you through the counseling of the caregiver and monitoring the children of those who are given these dolutegravir 10 milligram ART regimes. So first things first, the goal of this antiretroviral therapy in children are first to suppress the HIV replication. And thus by suppressing the HIV replication, we can enhance the immune system and thereby reduce the opportunistic infection. By reducing opportunistic infection, we can improve the quality of life of the patient and also decrease the morbidity of the children. This can promote growth, optimum growth and development in the child, and also prolong the survival of the child, because the child living with HIV is to be given lifelong ART therapy. So HIV, as we know, has a stigma and also a fear regarding social ostracism, and also the fact that lifelong therapy has to be given. So there we should spend some time in preparing the child for ART. And the first thing is to identify a primary caregiver of the child, because here we are talking of children who are less than 15 years of age, who require other family members to help them initiate the ART and adhere to that ART. So to identify a primary caregiver will be usually the parents or maybe some other family member. And if one of the parent or the guardian has HIV, then it is good to have a backup caregiver also. The initial assessment of the child, that is the WHO clinical stage, the laboratory assessment, the CD4 count, the CD4 percentage, the viral load, whether whether there are any opportunistic infections, including tuberculosis, including any pneumonias, any other hepatitis, whatever it may be, that should be evaluated, diagnosed, and managed. Also, as I was telling, that preparing and psychosocial counseling of the not only the child but also the caregiver should be done on the initial assessment day itself. Less than 5 years age children should be immediately started on cotrimoxazole preventive therapy, or CPT as we call it, and more than 5 years patients should be evaluated on the opportunistic infection status, on the CD4 status, and given cotrimoxazole preventive therapy or prophylactic therapy. Then we prepare the patient and the caregiver on the point that they are going to receive a lifelong therapy of antiretroviral drugs. So adherence to the regime is of vital and very important to promote the immune status of the child and to prevent the opportunistic infections. And also, before starting the ART, it is important to treat the patient of any opportunistic infection that he or she might be suffering, to stabilize the patient, because it might lead to iris or immune reconstitution inflammatory syndrome if the patient is not stabilized prior to the ART initiation. So to recap the steps of initiating ART in children, so first, confirm the HIV infection in infants and children serologically. That is, you do the immunological best test for children who are more than equal to 18 years of age, or if they are less than 18 months of age, and if they are less than 18 months of age, since the maternal antibodies might give a false positive reaction, they should be confirmed. The HIV should be confirmed virologically, that is by RNA PCR. After this, after the HIV is confirmed, the baseline assessment investigations and CD4 count. Baseline assessment investigation will include, since it is a child, the patient is a child, the growth and developmental milestones, and the weight of the child, height of the child, the head circumference, arm circumference, mid-arm circumference, everything should be taken into consideration. Whether he or she is suffering from any acute conditions or any opportunistic infections, that should be taken, that should be investigated properly. The symptoms should be taken into account. Especially whether he or she is cohabitating with people who are infected with TB, that should be taken into account. And finally, the various blood parameters, the CD4 count, the viral load should be done. After the baseline assessments, the cotrimoxazole preventive and prophylaxis should be started. And also, as I was saying, the preparedness counseling of the caregiver and child should be there for initiating this lifelong antiretroviral therapy. So, regardless of whatever stage the patient or the child comes to us in, whether it may be WHO stage 1 to 4, whatever it may be, whatever be the CD4 count, or in very young children, if the CD4 percentage, whatever it might be, regardless the age, it is good to initiate. The first line ART must be initiated as quickly as possible after the preparedness counseling. So rapid initiation of children who are living with HIV is advised after proper counseling and should be initiated regardless of what age the child is in, the CD4 count or CD4 percentage, and the WHO clinical staging. But in the same breath, let us understand that ART is a non-emergency intervention, and it is always required for the patient and for the caregiver to understand that the before initiation, proper counseling and proper preparedness, proper management of the opportunistic infections should be given a priority before initiating the antiretroviral drugs itself, because we are looking at a lifelong therapy, and lifelong therapy means that we need adherence to the treatment protocol. And if the child is very seriously ill, or if he or she is suffering from opportunistic infections or malnutrition, whatever may be the issue, then he or she should be hospitalized and stabilized. Otherwise, there can be the consequence of an iris in the patient. So coming to our primary objective, that is the dolutegravir based ART regimen in the children, in the child. So why do we prefer dolutegravir? Dolutegravir, it is more potent. Its half-life is very long. That is, if it is given once daily, it achieves the concentration and gives a response, and it rapidly achieves a decrease in viral load and also maintains the viral suppression. But since it is given once daily, it has a less pill burden, and giving once daily by giving once daily, we can achieve that viral suppression, and it can be administered easily. Nowadays, we have this dispersible dolutegravir tablets, which can be dissolved in water or milk and given to the child, which supports adherence. It is also evidence-based that dolutegravir is superior than the previous therapy, that is the ritonavir boosted lovinamide therapy. It also harmonizes with the adult regime, because all our adult regime has gone to TLD, that is dolutegravir is a must in them. And also it is easy for maintaining the supply chain. The advantages of dolutegravir dispersible tablets in children is that it is a once daily schedule. It is easy to administer. The taste is good, better than the lopinavir, ritonavir therapy, because that was a bit bitter. This is sweeter to taste. It is better tolerated, lesser side effects, but still we have to keep looking out for any adverse effect that the child might be suffering by proper follow-up. And then it has a very fast viral load suppression and also has a high genetic barrier for resistance. It can be given for both HIV-1 and HIV-2 and HIV-1, HIV-2 co-infection, which is a very good advantage of dolutegravir over the previous ones that we were using. So on the side, we find that this is a job card which describes how to administer the pediatric antiretroviral medicine with dispersible tablets, and how many tablets are to be given in which weight band, and how it is to be given, which we will be discussing in details. Now, the key consideration of pediatric ART regime is that abacavir is the first preferred NRTI for initiation, ART initiation in children. Lamivudine is the second NRTI and is a component for all patients. For children living with HIV who are less than 20 kgs, they are initiated on dolutegravir 10 milligram dispersible tablet based regime. For children who weigh more than 20 kgs, the dolutegravir 50 milligram film coated tablet is preferred third drug. And all those children who are more than 10 years and weigh more than 30 kgs, tenofovir is the preferred NRTI for ART initiation and not abacavir. So just to have another look at it, that dolutegravir 10 milligram dispersible tablets is for children less than 20 kg. Dolutegravir 50 milligram film coated tablet is for children weighing more than 20 kg. Whereas tenofovir 300 milligram is for children living with HIV who are more than 10 years and the weight is more than 30 kgs. So let us see the recommended first line regime once more, so that we get it into our minds as to the what regime we are going to follow depending on the weight band. So if the weight of the child is less than 20 kgs, we give abacavir lamivudine along with dolutegravir tablet 10 milligram once daily. Now, fixed dose combination of abacavir and lamivudine as per the weight band is given twice daily, whereas pediatric dolutegravir 10 milligram tablet as per weight band is given once daily. If the weight is between 20 to 30 kgs, then the fixed dose combination of abacavir and lamivudine is given twice daily as per weight band, and the film coated dolutegravir tablet 50 milligram is given once daily. And if the weight is above 30 kgs, or if the age of the child is above 10 kgs, then we go for the TLD regime, which is the fixed dose combination of tenofovir, lamivudine and dolutegravir once daily. So I was talking about the weight band. So this weight band is given in the, we follow the pediatric drugs dosage chart, which was a part of the HIV care guidelines of 2021. So this is the pediatric, thank you. This is the pediatric dosage chart, and this was there in the guidelines way back in 2021. And now we are talking about the dispersible dolutegravir tablets, which is given at the end. The last two rows where dispersible dolutegravir 5 milligram and 10 milligram scored dispersible tablet is available now for dispersing for giving to children who are less than 20 milligram 20 kg in weight. So if the previous chart looks confusing, we have a better one or a much more explanatory one over here, where children living with HIV who are weighing less than 20 kgs are divided into 4 weight bands. The first weight band is from 3 to 5.9 kg. The next one is from 6 to 9.9 kg. Followed by 10 to 13.9 kgs, and the last is from 14 to 19.9 kg. Now for the first child, if the child weight is from 3 to 5.9, the first row, then the dose of dolutegravir dispersible tablet once a day is half the tablet, that is 0.5 of the tablet has to be given, along with a single tablet twice daily of the abacavir lamivudine fixed dose combination. And if zidovudine lamivudine is chosen, then 60-30 fixed dose combination is given, 1 tablet twice daily. So please remember, the dolutegravir is given half tablet once daily, whereas the NRTI combination is given twice daily. Now coming to the next weight band from 6 to 9.9 kgs. So the dosage of dolutegravir is 1.5. That is, you have to take 1 full tablet and break another, that is 1.5 tablet once a day. This is a dispersible tablet, and 1.5 tablets of the fixed dose combination of lamivudine and abacavir twice a day. And if the patient is on zidovudine lamivudine, then that is also 1.5 tablets twice a day. Now for 10 to 13 kg, 13.9 kg, the dose of dolutegravir 10 milligram tablets will be 2 tablets once a day. The abacavir lamivudine fixed dose combination tablet will be twice a day, 2 tablets twice a day. And if it is zidovudine lamivudine, then 2 tablets twice a day. And if the child is more than 14 to less than 19.9 kgs, then the dosage of dolutegravir is 2.5 tablets once daily of dolutegravir 10 milligram, twice daily tablets of 2.5 tablets of the fixed dose combination of abacavir and lamivudine. So it is good to understand that this dispersible pediatric dolutegravir, which contains 10 milligram, is not bioequivalent with the film coated tablet. So we cannot say 50 milligram of the dispersible pediatric dolutegravir is equal to 50 milligram film coated. It is of the equivalence of 30 milligram of dispersible dolutegravir, and 30 milligram of dispersible dolutegravir is equivalent to 1 film coated 50 milligram dolutegravir tablet. So if we are trying to switch, we should, or if we are trying to replace the 50 milligram dolutegravir, so we should do that with 3 10 milligram dolutegravir dispersible tablet. So it is all our next case scenarios are based on this weight band and how many dosage of the tablet. So if anyone is interested, you can take a picture of this for the next case scenarios. So coming to the counseling or preparedness counseling of the dolutegravir 10 milligram based ART, we have to explain what, we have to specify when, and we have to identify who. Explain what means we have to explain to the patient and the caregiver that dolutegravir 10 milligram is a dispersible scored tablet. By scored tablet, we mean that it can be broken in half from the middle, and there is a fine line by which that can be done. Also, that if the child vomits out the dose, then if the vomiting occurs within 30 minutes of taking the medicine, then the dose must be repeated. If vomiting occurs after 30 minutes, then the dose may not be repeated. Specify when, that is dolutegravir 10 milligram can be taken with or without food. It has no food interactions, but the dose should be fixed, because we are talking about adherence, and only by being adherent we can achieve a very less viral load in the children living with HIV, and the dose should be fixed once a day, and should be given at a fixed time, so that remembering taking the dose is so the patient can remember taking the dose, and each dose can be can be taken. So also it is good to ensure when the child is going to take the tablet, because in the morning it is expected the child will be going to school, will be playing. So it is good to have a proper time which is linked to the routine of the child. So make sure that the child or the counseling should have that the child should be taking the tablet at a routine time, and this routine will be fixed according to the child's routine. And identifying who will be giving the tablet, it is usually the primary caregiver which has to be identified. It can be the father, it can be the mother, it can be the grandparents, or any other guardian that the child is living with. And if the primary caregiver is a person living with HIV, then it is good and essential to have a backup secondary caregiver, because if the primary caregiver falls sick, then someone will be there to give the child his medicine. So pre-ART activities will be that pill swallowing or giving the first doses of the ART in the hospital itself. Now, how to give this dispersible DTG dispersible tablet? So this dispersible tablets, 10 milligram dolutegravir, they are dissolved in drinking water in a clean cup, and the amount of water that has to be taken is already specified in the table just on the side, that if you are to dissolve half a tablet to 4 tablets, then 5 ml or 10 ml should be sufficient, which equals to 1 to 2 teaspoons. And if dolutegravir is to be given with the fixed dose combination of avacavir lamivudine or zidovudine lamivudine, which also are dispersible tablets, then the amount of water has to be increased to 20 ml or 4 teaspoons. The suspension should be swirled and should be uniform so that no lumps remain, and should be given immediately. By immediately, we mean that it should be given within 30 minutes of mixing the suspension. And the small amount of water should be taken in the cup in which the medicine was prepared, and this additional water should be fed to the child to ensure full dosage of the drug. Now, dispersible tablets can be swallowed as a whole beyond 5 years of age, but it is good to have one tablet at a time swallowing, so that it avoids choking. Now, scored tablet can be split with dry and clean hands. As I have said, that scored means there is a line by which you can break the tablet into 2 equal halves, and the other half which is not used, that is to be returned into the bottle. So can we give dolutegravir 10 milligram 3 tablets for children living with HIV who weigh more than 20, that is 21 kg to 29 kg. Now, use of this dispersible tablets is limited up till, as we have said, till 19.9 kg. After 20 kg of weight, the child is given dolutegravir film coated 50 milligram tablet. Now, it can be a possibility that the child is not able to swallow the film coated tablet. So what do? We have two options. Either we split the 50 milligram tablet into 2 halves, or we crush it and apply and mix a small amount of semi-solid food and liquid, and that is consumed totally. Or we can give 3 tablets of dolutegravir 10 milligram dispersible tablets by dispersing it in water. So this is because though it is 30 milligram of dispersible tablet is bioequivalent to 50 milligram film coated tablet. So if the child cannot swallow a film coated tablet, it is good to either split or crush the tablet and feed to the child, or have 3 tablets of dolutegravir 10 milligram dispersible, which you can disperse in water and feed to the child. Now, can dolutegravir be taken with food or milk? Yes, it can be taken with or without meals because it has no food interaction. It is a dispersible tablet and should be dispersed ideally in water, but it can be taken with food or milk. What are the counseling messages for the caregiver and the child in which the ART is to be initiated? The primary thing is to explain that ART is going to be lifelong. So importance of adherence and thereby viral suppression is a must. So even if the viral load comes down to target not detectable, still ART has to be continued lifelong because the virus resides in some reservoirs and they can come back and cause the infection again. So the need for lifelong ART has to be stressed, and the importance of adherence. Every day the drug has to be taken. This has to be told to the child and the caregiver. While counseling the caregiver and the child, the benefits of dolutegravir has to be explained that it is an effective drug. Very quickly the virus gets suppressed. It is safe. By safety, we mean that there are very less adverse effect, and also it is easy to administer. The 10 milligram tablet is a dispersible tablet which can be dissolved in water or milk or food and given to the child very easily. Also explain the uncommon side effects. These uncommon side effects can be fatigue, tiredness, insomnia, headaches, rash, and if there is anything regarding that, that should be reported immediately to the physician. Explain also about the weight gain that may occur due to dolutegravir. So dolutegravir can cause hyperglycemia, can cause weight gain, and if there is weight gain, since we are monitoring the growth and development of the child, the proper nutritional counseling, proper exercise should be counseled. Also explain how to give the drugs. We should understand and also make the caregiver understand that the dose of ART or the dose of dolutegravir is based on the weight of the child. So as the child gains weight as he or she grows up, the dose will change. So suppose he is starting with half a tablet of 10 milligram dolutegravir, that will increase as the weight of the child increases from 3 to less than 20. So it is important also for the counselor to tell to the caregiver and the child that fix the time of giving the drugs, because by fixing the time of giving the drugs you can adhere to the regime, and the regime can be monitored. Also dolutegravir should be taken 2 hours before or 6 hours after taking any cation containing antacid or laxatives like sucralfate, oral iron supplements, oral calcium supplements, or buffered medication. So if these cation containing antacids are taken or laxatives are taken, maybe some might suffer from anemia, so you are giving iron supplements. Someone may suffer from rickets, you are giving oral calcium supplements. Whatever it might be, make sure dolutegravir is taken 2 hours before giving that, or if it is already given, 6 hours after taking these medicines. Now, it is also good to understand that there are some drug interactions with dolutegravir, though they are very less. Now, drugs like the anti-epileptic drugs like carbamazepine, phenytoin, phenobarbital, they are all cytochrome P450 inducers. So they induce the enzyme, and by inducing the enzyme, they also induce the metabolism of dolutegravir. So if the metabolism of dolutegravir is increased, that means less amount of dolutegravir will be available for the desired action. And if these anti-epileptics are used, then the suggested management will be to use dolutegravir twice daily, or you can substitute carbamazepine, phenytoin, phenobarbital with some other alternative anticonvulsant agents which are not enzyme inducers, like valproate, like levetiracetam, like topiramate. Also, as I have earlier said, that cation products containing aluminum, calcium, iron, magnesium, zinc, for example, iron supplements, calcium supplements, multivitamins, antacids, when these drugs are to be given, it is dolutegravir should be given at least 2 hours before or 6 hours after giving these polyvalent cation containing products. Now coming to a very important drug, that is rifampicin, which is given for co-infection with TB and HIV. Since rifampicin is also a drug inducer, it is dolutegravir dose has to be increased to twice daily. Now, rifampicin forms a component of the drug-sensitive tuberculosis regime. So, if the child is receiving rifampicin, then the dolutegravir instead of once daily has to be given twice daily. But if the child is on the drug-resistant TB regime where rifampicin is not used, then we can go along with dolutegravir once daily. Now coming to amodiaquine, which is an anti-malarial drug. If amodiaquine is used, then dolutegravir interacts with amodiaquine. It is good to use an alternative anti-malarial agent. We have numerous now. We have the artesunate combination therapy or the ACT, which can be used instead of amodiaquine in these children who are receiving dolutegravir. Now coming to the case scenario 1. So here, can anyone read to me this case? Is anyone there to read the case? Or should I read it myself? Shweta ma'am, can you read it to me? The first case? Okay, so let me read it. So, Miss Y, who is an HIV infected child aged 2 years, she has persistent oral thrush. She has achieved normal developmental milestones but has failed to gain weight and height as expected. So, the weight is 6 kg, which is less than -3 Z scores, and the height is 72 centimeter, which is less than 3 Z scores. The CD4 count is 18%. The hemoglobin 7 gram percent and TB has been ruled out. So the first question is, what is the clinical stage of the child? Now, as you can see, the HIV infected child, the height and weight are below -3 Z score. So we say from -2 to +2 Z score, the child is okay. And beyond that, in either ways, then the child is suffering from malnutrition. So severe malnutrition means the clinical stage of the child is WHO stage 4, that is severe malnutrition. And if the patient is suffering from severe malnutrition, the child should be evaluated by a pediatrician regarding how to properly manage the child regarding the feeding issues and the infections. So is the cotrimoxazole preventive therapy indicated in child? So as you can see, the child is aged less than 2 years. We always say the cotrimoxazole prophylaxis is a must for all children less than 5 years. So yes, irrespective of the clinical stage, that is WHO stage 4 or the ACD4 count, which is 500, we have to give cotrimoxazole prophylaxis to this child since she is less than 5 years of age. And this dose is syrup cotrimoxazole 5 ml once a day. Now, what needs to be done before ART initiation? Before ART initiation, we have talked about that we have to do some preparedness counseling and baseline assessment of the child. So, baseline investigations including CD4 count and percentage, screening and management of the opportunistic infections, including the 4 screening for TB, that is whether the child is suffering from cough, from weight loss, from fever, or is in contact with a TB infected person, preparedness counseling regarding lifelong ART therapy, and identification of the caregiver. The cotrimoxazole prophylaxis or preventive therapy is initiated, and its adherence is to be checked in the initial visits. Management of severe malnutrition is essential, and since here the patient is severely malnourished, she might need hospitalization. Now, what should be the ART which is prescribed to the child? Now, the child is aged 2 years and the weight is 6 kg. So, as we remember, this weight-based guidelines, that dolutegravir, we are talking about this second weight band, that is 6 to 9.9 kg. The weight of the child is 6 kg. So the dose of Dolutegravir 10 milligram tablet is 1.5 milligram 1.5 tablets once a day, whereas the dose of the fixed dose combination of abacavir lamivudine is 1.5 tablets twice a day. So keeping this weight band in mind, the weight of the child 6 kg, the ART regime will be abacavir lamivudine 1.5 tablet twice a day and dolutegravir 10 milligram 1.5 tablet once a day. So in ART naive children with HIV, first confirm the HIV infection virological or serological testing, stabilize any acute condition or any opportunistic infection by, and also do a baseline CD4 count, the viral load and other lab investigations. Measure the weight and age of the child, because the weight of the child will make you understand which regime to go with. If the weight of the child is less than 20 kgs, then we go for abacavir lamivudine and dolutegravir 10 milligram. Then if the weight is between 20 to 30, we give abacavir lamivudine along with the film coated 50 milligram dolutegravir tablet, that is ALD regime. If the child is more than 10 years and the body weight however is less than 30 kg, then we go for the previous regime, that is abacavir lamivudine and dolutegravir film coated tablet 50 milligram. And if the body weight is more than 30 kgs, more than equal to 30 kgs, then we rule out any renal disease, because as we know, if there is a renal disease, we go for the abacavir lamivudine dolutegravir tablet. But if because if the person, if the child is suffering from some known renal disease, then tenofovir can cause further enhancement of the renal disease, and we usually do not prescribe tenofovir, we go for abacavir. And if there is no renal disease, then we go for the TLD regime in children who are more than 30 kgs and more than 10 years of age. Now coming to the prescription writing, we have some problems over here. The first problem being that the child is 6 years of age, the weight is 13 kg, he's a male child, the hemoglobin is low, that is 8 gram per dl, and the CD4 count is 500 cells per millimeter cube. So let us see, this is the weight band. So according to the weight band, 13 kgs falls to the third weight band. So two tablets twice daily of abacavir lamivudine, 2 tablets once daily of dolutegravir dispersible 10 milligram tablets, and since the child is suffering from anemia, you have to give a hematinic tablet, that is iron syrup has to be given. Now coming to the next problem, that is a 7-year-old child whose weight is 19 kg, female child, hemoglobin is low and the CD4 count is 300 and there are no opportunistic infection. What do we do? Now since the weight of the child is 19 kg, the female child falls to the fourth weight band, and in that weight band we have 2.5 tablets once daily of dolutegravir dispersible 10 milligram and 2.5 tablets of the fixed dose combination of abacavir lamivudine twice a day. And along with that, you can give a hematinic tablet, and since the CD4 count is low, you have to give cotrimoxazole prophylaxis, single strength 1 tab daily. Now coming to the third problem. The third problem, we have a weight 3-year-old child, male child, who weighs 9 kgs. The hemoglobin is not available. The CD4 count is 400 and there are no opportunistic infections. So the weight is 9 kg, that means the second band. So 1.5 tablets of dolutegravir dispersible 10 milligram and 1.5 fixed dose combination of abacavir and lamivudine twice a day is to be given. And along with that, since the child is 3 years old, that is for every child who is less than 5 years of age, we have to give cotrimoxazole prophylaxis. So cotrimoxazole syrup 5 ml once a day is given. Coming to the fourth problem, the 4.5 months old infant weighing 4 kg is diagnosed HIV infected. there are no opportunistic infections. So weight is 4 kg, which means the child is in the first weight band. So half a tablet of dolutegravir and one tablet twice daily of the fixed dose combination of lamivudine and is to be given along with cotrimoxazole prophylaxis 2.5 ml syrup once a day. So this is more or less a snapshot according to the various weight band, how the dose of dolutegravir will be given, how many dose of the fixed dose combination of abacavir lamivudine is given, and if the patient is anemic, we can give a hematinic syrup. The cotrimoxazole prophylaxis has to be given for any child less than 5 years, and then according more than 5 years according to the CD4 count. Coming to the case scenario 2, so Master Z is a 2-year 9 months old infected HIV infected boy, and he presents with altered sensorium. Altered sensorium or maybe less conscious, unconscious state since 2 days, and he had cough and fever for the last month, 1 month. His father was recently detected to have pulmonary TB, and he was diagnosed to be suffering from TB meningitis. He was started on anti-TB treatment 14 days ago. His body weight is 9 kg, CD4 count is 14%, and hemoglobin is 9.8 gram per DL. So this is a case of TB meningitis and HIV co-infection. So TB meningitis is one of the opportunistic infections that occur in HIV. And since he had a contact history, he was having cough and fever for 1 month. So this TB meningitis has to be taken care before we can start the ART. So let us look at the questions. So is cotrimoxazole prophylactic therapy indicated in this child? So this child is 2 years and 9 months. So yes, he is less than 5 years. So he has to take the cotrimoxazole prophylaxis 5 ml syrup once a day. And he also is in clinical stage 4 since he has TB meningitis, has altered sensorium. The next question is, when should ART be started in this child with a TB HIV co-infection? In the initial parts of the slide, I have already discussed that any opportunistic infection, and in this case, it is a TB meningitis. So this TB has to be dealt with, or the patient has to be stabilized before HIV ART is started. So there is a fixed plan, fixed routine of when to give ART. It is since the child is having TB meningitis, the ART is to be started 4 weeks after the 4 weeks after the TB treatment, but say within 8 weeks of the start. And since TB meningitis is detected, so corticosteroids should be added as an adjuvant therapy for TB meningitis. So let us look at the scenario once more. So the child is co-infected with TB, and regarding the timing of start of ART, so timing of ART has to be delayed. So just then we can't start ART because the patient is not stable, and also there is risk of iris. So what do? We initiate the TB treatment first, and as soon as the patient is stabilized, then we start the ART treatment. Now, if the patient is not suffering from TB meningitis, but maybe only a pulmonary TB or an extrapulmonary TB, then the ART should be started as soon as possible within 2 weeks of TB treatment initiation, regardless of the CD4 cell count, except when signs and symptoms of meningitis are present. When signs and symptoms of meningitis are present, as was in this child, then what do? We delay the ART treatment for at least 4 weeks, but we have to initiate it within 8 weeks after stabilization of the patient. And for TB meningitis, corticosteroids should be considered as an adjuvant treatment for these patients who are having altered sensorium and are unstable and hospitalized. So this same case, what should be the ART regime with the dose prescribed for him? Now this ART regime will change a bit. Why? because this ART regime is to be given along with the TB regime, and this TB regime has rifampicin in it. Just as we have discussed a few slides back that rifampicin is a drug inducer. That means it induces the enzymes which metabolize the drugs, not only itself but also the other drugs which are co-prescribed, and in this case it is dolutegravir. So what we do is we increase the dolutegravir dose. Instead of giving one tablet, we give two tablets, or twice daily dosing of dolutegravir is done. And since the child is of 9 kg, we give abacavir lamivudine fixed dose tablet 1.5 tablet twice a day and dolutegravir 1.5 tablet twice a day. So if the child was a treatment naive child without tuberculosis, without having initiated anti-TB treatment, then we would have given dolutegravir 1.5 tablets once a day. But here we give 1.5 tablets twice a day because the enzyme which induces dolutegravir or which metabolizes dolutegravir is the one which is getting induced. So the effective dose of dolutegravir will decrease. So we have to give twice a day. And this has to be continued till 2 weeks after stopping the anti-tubercular treatment, after which dolutegravir can be given in a once daily dose. So modification of the dolutegravir based ART treatment in those patients who are receiving rifampicin based anti-tubercular treatment is that if DTG based regime, then we double the dose of dolutegravir. The dose is to be given twice daily for 2 weeks after the last dose of rifampicin. That is, after the ATT regime has ended, we continue dolutegravir twice daily. For 2 weeks after that, we give dolutegravir once daily. And if the regime contains ritonavir boosted lopinavir, then what is done is we do super boosting of lopinavir in the ratio of 1:1, and this modification is also given for 2 weeks after the last dose of rifampicin. Now coming to, again, it is a revision of the first line ART regime in ART naive patients who are co-infected with TB. So if the weight is less than 20 kg, then we have this ALD regime. The fixed dose combination of abacavir lamivudine twice daily as per weight band plus dolutegravir 10 milligram tablet twice daily as per weight band. If the weight is between 20 to 30 kgs, then the regime is ALD, where TLD, where dolutegravir 50 milligram film coated tablet is given twice daily, and abacavir lamivudine fixed dose combination is given as per weight band twice daily. Now, if the weight is above 30 kgs and if the age is above 10 years, then we shift to the TLD regime, and here also additional tablet of dolutegravir 50 milligram is given after 12 hours. So it is good to understand that the increased dose of dolutegravir which we are giving has to be continued till 2 weeks after the last dose of rifampicin. And rifampicin is a part of the drug sensitive tuberculosis cases treatment regime. But in those patients who are having drug resistant tuberculosis, there is no rifampicin in the therapy, and so there is no requirement of changing the dose of dolutegravir. So, in children with HIV with drug sensitive tuberculosis, if the weight is from 3 kg to 5.9 kg, it is half a tablet twice daily. From 6 to 9.9, 1.5 tablet twice a day. From 10 to 13 kg, 2 tablets twice a day. 14 to 19.9 kg, 2.5 tablets twice a day. And more than 20 kg, they are on TLD regime. So other than the fixed dose combination of tenofovir, lamivudine and dolutegravir, another 50 milligram dolutegravir film coated tablet is to be given twice a day. So coming to the case scenario 3, here Master S, who is an HIV infected boy, aged 7 years, is presently asymptomatic, clinically stable, no opportunistic infections. The weight is more than 20 kg, that is 24 kg. The CD4 cell count is 386. Hemoglobin is looking good, 12.6, and other investigations are within normal limits. So is cotrimoxazole prophylaxis or preventive therapy required? So this boy, he is aged 7 years and his CD4 count is also more than 350 cells. So he he may not be given a cotrimoxazole prophylaxis therapy because he is presently asymptomatic. His CD4 count is more than 350 and he is more than 5 years. So what is the regime in this boy? The ART regime in this boy, the boy weighs 24 kgs. Now we have to give the ART regime, that is ALD. ALD, how much do we give? We give 3 tablets of abacavir, lamivudine fixed dose combination in 3 tablets in the morning and 3 tablets in the evening. We usually give a gap of 12 hours, and along with that, once a day, a film coated tablet of dolutegravir 50 milligram. Coming to case scenario 4, so Miss T is a 13-year-old girl, and this 13-year-old girl is ART naive, asymptomatic, and in clinical stage 1. The weight is 38 kg, hemoglobin is 10, the CD4 count is 458. The renal functions are within normal limits and other investigations within normal limits. So the weight of the child is more than 30, that is 38 kg, hemoglobin 10, and the CD4 count is more than 350. So is CPT indicated? As we have seen in the previous case, the child is more than 5 years and his CD4 count is above 350. So there is no indication of cotrimoxazole preventive therapy in this 13-year-old girl. And now coming to the prescription of ART regime with this dose. So what do we give? Since the child is above 30 kg, we can start TLD, and the renal functional tests are within normal. So we can give tenofovir. Tenofovir has some limitations of that. It can cause lessening of the bone mineral density, and also it has renal, it can increase the creatinine, it can increase the creatinine, that is the renal function abnormality. So if the patient is above 30 kgs, the renal function test is done. If the renal function test is normal, we can proceed for tenofovir based therapy, that is TLD. And if the patient is having abnormal renal functions, we can go for the ALD or abacavir based regime. So in this case, the patient is 38 kg, she is having normal renal function. So one tablet of TLD once daily as has to be given to the patient according to the time that is suitable for her. So till now we were discussing more or less about the treatment naive patients. Now we go for the flow chart, which describes the transition to those patients who were on some other regime in ART, and they are to be transitioned to dolutegravir 10 milligram based ART. Now the algorithm, if we see from first, if the child is ART naive, then we go for the fixed dose combination of abacavir, lamivudine, and dolutegravir based on the body weight. Now, if the child has previous exposure to antiretroviral therapy, then we take into consideration the weight of the child. If the weight of the child is less than 20 kgs, then we see whether the child has been on ART for 6 months, more than 6 months, or less than 6 months. If it is less than 6 months, then we transition to the fixed dose combination of abacavir, lamivudine along with dolutegravir based on weight band without conducting the viral load test. But if the patient is on ART for more than 6 months, then before transition, the viral load has to be tested. And if the viral load comes suppressed, that is less than 1000 copies per ml, then it is a good time to transit to dolutegravir 10 milligram. But if the viral load is not yet suppressed, is more than equal to 1000 copies per ml, then we go for 3 months enhanced adherence counseling, and we repeat the same regime. After repeating the same regime and have done the enhanced adherence counseling, then we go for the viral load again. Now, if the viral load after 3 months comes less than 1000, that is suppressed, then we can transition to dolutegravir. But if it does not come unsuppressed, then or more than equal to 1000 copies per ml, then we have to switch according to the table which is given just on the side. That is, if the patient was on abacavir, lamivudine, and ritonavir boosted lopinavir therapy, if the viral load is suppressed, that is less than 1000 copies per ml, then we transition to AL and dolutegravir. If it is unsuppressed, if the viral load remains more than equal to 1000 copies, then we shift to either zidovudine based dolutegravir therapy if the hemoglobin is above 9 gram percent, because here the patient is already exposed to abacavir once. But if the patient has a hemoglobin less than 9 gram percent, then we have to give abacavir, lamivudine along with dolutegravir. But this transition should be done under guidance of the Pediatric Center of Excellence and the state administration, state AIDS control uh, people. And if the patient was receiving zidovudine, lamivudine along with ritonavir boosted regime, if the copies are suppressed, then go for transitioning to dolutegravir, keeping the zidovudine lamivudine combination. But if it is unsuppressed, if not exposed to abacavir, then go for abacavir, lamivudine, dolutegravir. And if exposed to abacavir, then we continue zidovudine, lamivudine, and along with that we transition to dolutegravir. But these patients have to be taken care of more and should be under guidance of the SACEP and the Pediatric Center of Excellence. So, a quiz on the transition situation of children living with HIV who are less than 20 kgs. So, the first situation is the fixed dose combination of abacavir, lamivudine, and lopinavir is given, and the viral load is suppressed. So, if the viral load is suppressed, then we can smoothly transition to the dolutegravir 10 milligram as per the weight band. Coming to the next situation where zidovudine, lamivudine is given along with lopinavir. Now, the viral load shows that the viral load is suppressed to 800 copies. Even in this case, we can go for ZL and dolutegravir as per the weight band. Now, the third situation is that the patient was receiving abacavir, lamivudine, lopinavir, and the viral load shows a count of 1200 copies. That means it is not yet suppressed. So, so the same regime is given for 3 more months. Enhanced adherence counseling is done, and viral load is done again. And here 600 copies are to be found. That is, the viral load has suppressed. So in this case also we can transition to abacavir, lamivudine, and dolutegravir based on the weight band. Coming to the next situation where zidovudine, lamivudine along with lopinavir is given. Initially there was a viral load of 800 followed by target not detected after 3 months. So here in this case also we can transition to dolutegravir and keeping the zidovudine, lamivudine in the fixed dose combination. Now the next two situations are that even after enhanced counseling, the viral load has not decreased. In fact, it has increased. So the patient is on abacavir, lamivudine, and lopinavir. The initial viral load was 1200 copies. After 3 months of enhanced adherence counseling and giving the same regime, the viral load again comes unsuppressed, that is 2600 copies. So what do we do in this case? In this case, we have to consider the hemoglobin of the patient. And if the hemoglobin of the patient is less than 9 or above 9 gram percent, if it is above 9 gram percent, since the patient is already exposed to abacavir, then we shift to zidovudine, lamivudine, and dolutegravir. But if the hemoglobin is below 9 gram percent, then we do not give zidovudine, we give abacavir, lamivudine, and dolutegravir. but make sure these patients are under strict guidance of the pediatric uh, excellence center. Now coming to the next situation, which is more or less the same, just the patient is on zidovudine, lamivudine. The viral load has not suppressed even after 3 months of enhanced adherence counseling and following the same regime. So in this case, we see whether the patient has been previously exposed to abacavir or not. If the patient has not been exposed to abacavir, we go for abacavir, lamivudine and dolutegravir. And if the patient is exposed to abacavir, then we keep the zidovudine, lamivudine fixed dose, and along with that, we give dolutegravir. But please make sure these patients are under strict guidance and control. So other than that, the follow-up of every child will require the measurement of the weight, height, the head circumference, mid-arm circumference, to monitor the growth, developmental progression, the milestones, and the nutrition of the patient. Because the antiretroviral dose, whether it be the fixed dose combination of abacavir, lamivudine or the dolutegravir tablets, is based on the weight. So as the child grows, as he or she gains weight, the dose will change, and that has to be calculated at every visit. So other than that, the treatment adherence should be maintained. It should be seen to it should be seen that how many tablets the child is consuming and how many tablets they were given, and the clinical monitoring of any opportunistic infections that might be starting, and the staging of the uh, patient should be done. The 4S screening of tuberculosis, that is whether the patient is having cough, fever, loss of body weight, and whether he or she is in contact with a member of the family who is having active tuberculosis. Everything should be screened at every visit and should be monitored. So it is good to note that the national guidelines in 2021 also said that at every visit, check the body weight of the child, of the infant, because any change in body weight might result in, because they are very small weight bands, and any small change, a 0.5 change, might put the child into a different weight band altogether. So some facts about the monitoring of dolutegravir. So as I have said, that dolutegravir has very few side effects, and that side effects should be inquired into. It is usually fatigue, insomnia, some rash, but it is always good to tell the caregiver and the child that some extra monitoring is required regarding the blood sugar level and the weight, because it is seen that dolutegravir can increase the blood sugar level, leading to hyperglycemia. So in the children who do not have diabetes between the weight of 6 to 12, should usually have the normal blood glucose level fasting before breakfast from 70 to 120 milligram per dl, and after 2 hours after meal, which should be less than 140 milligram per dl. So any deviation from this puts the child under scanner for development of hyperglycemia. And if there is increasing hyperglycemia in those patients who are already suffering from type 1 diabetes, then uh, the dolutegravir is not required to be changed, but uh, the but but it is good to monitor the child for the diabetes, and recommend all the actively screen the patients for risk factors of hyperglycemia, and follow up, and thereby possible association between dolutegravir and hyperglycemia. So if the child is having too much of weight gain, and the child is on dolutegravir 10 milligram, so it is found that weight gain is observed in adolescents receiving dolutegravir, and also adults. But still now data is coming in for children, and there are further studies that are going on in children, whether they really gain weight when on dolutegravir 10 milligram, and that should be monitored. So case scenario 5. So Master Q, who is a 6-year-old and weighs 13 kg, he was started on ALD regime on July 2023. He was issued 120 tablets of AL and 60 tablets of dolutegravir. So He is taking dolutegravir in the evening at 7 p.m. He has come for drug collection on 29th July. So pill box has AL fixed dose tablets 10 in number and dolutegravir 6 in number. So here actually we are concerned about the treatment adherence, how many tablets the patient has been given and how many tablets he is returning with. That we are supposed to calculate to look at the adherence of the patient, because the more adherent the patient is to the regime, the less viral load he will be suffering from. He will be having the less opportunistic infections he'll be getting. So this patient actually he weighs 13 kg, and by 13 kg we mean that the patient is in the third weight band and should receive two tablets once daily of dolutegravir and two tablets twice daily of AL fixed dose combination. So that how to calculate the treatment adherence. Before calculating the treatment adherence, let us look at the formula. So adherence is calculated by the pill count method. That is the number of pills which are given minus the number of balanced pills, how many he has come back with, divided by the number of pills the patient should have. Should have means the dose into the number of days into 100. So this is the formula for calculating adherence. And so the AL dose is two tablets twice daily. 30 days tablets were given. So 30 into 4, 120 tablets of AL, and two tablets once daily of dolutegravir is to be consumed according to the patient's weight band. So 30 into 2, that is 60 tablets were given. Now the number of tablets that should have been consumed should be, because the patient returned on the 29th day, so he should have consumed at least 28 days medication, that is 28 into 412 tablets of AL and 28 into 256 tablets of dolutegravir. Now actual how many he came back with? He came back with 10 tablets of AL. That means 120 minus 10, 110 tablets he had consumed, whereas he had come back with 6 tablets of dolutegravir, that is 60 minus 6, that is 54 tablets of dolutegravir he should have consumed. So, uh, so the treatment adherence is the drug consumed divided by the drug he should have consumed into 100, which comes to 98% in the AL fixed dose combination and 96% in the dolutegravir combination. So, if treatment adherence is taken as the least treatment adherence drug, so which becomes 96%. So 96% is a good treatment adherence, because we consider more than equal to 95% as a good treatment adherence. But anyway, counseling should be done that 100% achievement should be, so that 100% achievement of adherence should be there. So to conclude, uh, introduction to the DTG dolutegravir 10 milligram pediatric tablet, which is a dispersible tablet. It is potent, it is effective, it is safe, and it has a more simplified regime, and it is harmonized with the adult regime. Now, the DTG is used across different regimen, either in the first line or in the second line management of HIV. It is well tolerated. It has few adverse effects, few adverse effects are usually reported, which are minor and self-limiting, like insomnia, like fatigability, mild rashes. They are well tolerated. The treatment preparedness and adherence counseling should be done before the ART initiation and transition, because the patient is a child living with HIV and he or she has to be given lifelong ART, because there is because for this adherence the counseling should be there, the treatment preparedness should be there, which we were talking about. Now these are the job cards which will be available, and one is there in English and one is there in Hindi, and you can scan the codes and download the job cards, the job aids, and here the easily you can understand how many tablets are to be given in what weight band. So that is it can be easy for those who are counseling the patient, for those who are making the caregiver understand how many drugs has to be given, how they are to be diluted, how they are to be prepared, and when they are to be given. So everything is there in this job aid. With this, I thank you all for listening to me, and I acknowledge my HOD, Professor Deepak Kumar Sharkar, Ms. Sweta Patil, Dr. Prashanjit Shaha, and Mohammad Ghazi for helping me prepare and uh, give you this presentation. Thank you.
Thank you so much, ma'am. Any questions from the participants? Please feel free to unmute.
Ma'am, I am Dr. B.N. Tripathi from Bhubaneswar ART Center, Odisha.
Yes, sir.
My question is, suppose a pediatric patient was started on ALD and but later on he grows in such a way that his weight reaches 30 kg, but his age is below 10 years. Can
Okay.
we shift to TLD?
Yes, because if the patient, I had a chart which showed, I had a chart that if the patient is more than 10 years, then we should look at the weight of the child. Fine. Now, if the weight is less than 30 kgs, then we go for the Abacavir based regime. But if the weight is more than 30 kgs, then we do a renal profiling of the patient. If the renal profiling comes okay, then we go for TLD regime, that is tenofovir based regime, because tenofovir is known to cause renal toxicity. So if the renal profile is okay, you can well go ahead with TLD regime for those patients who are suffering from those patients who are more than 10 years and more than 30 kg. But if it is found that the renal milieu is compromised, then you have to shift again to the ALD.
Madam, in this transition, if it is transitionable in this to TLD based regimen, then which is more important, the age or weight, body weight?
It is the weight primarily, and the I think I showed the. Can you go back to this? I'll show you the slide once more, sir. Just wait, because above 10 years, we have a separate view of the thing, that whether after 10 years how much is the weight. Just a moment, I'll just show you the. I think I've discussed that. Just a moment.
Because, madam, due to dolutegravir, many
Yeah,
children
please.
gain weight.
So please see this, doctor, that more than 10 years, that is the last one, more than 10 years, we look at the body weight. If the body weight is less than 30, then we go for ALD. And if it is more than 30, then we see the renal profile of the patient. If the renal profile is compromised, we go for ALD. If it is not, if the renal profile comes good, then we go for TLD. Okay, sir?
That's okay, madam. My question is, age is below 10 years, suppose 9.5 years.
Yes.
Body weight is 30 kg.
Okay.
So can we shift to TLD?
If it is 30 kgs, then you can go for TLD, sir, because anyway you are going to put him on TLD after 6 months, right?
Do we need viral load testing in this case and wait for 6 months and do viral load testing?
No, viral load testing is not the main issue here, sir. The main issue is the renal disease.
Okay. Okay, thank you, ma'am.
Okay, welcome, sir.
Any more questions? Participants can please unmute and ask questions. Ma'am, can we quickly run the feedback form? Kiran sir, can we have the feedback poll? Thank you. The feedback poll is now visible on your screen. All the participants are requested to please attempt all the questions. There are 5 questions in all. Please click on the answer of your choice. Requesting all the participants to please answer the feedback poll.
No more questions.
No more questions, ma'am. We'll just quickly run through the feedback poll. Give me 2 minutes, ma'am, please.
Okay.
Thank you. Requesting all the participants to please attempt the feedback poll. Click on the answer of your choice. We'll wait for another minute. Only 3 participants have attempted the poll. 4. Requesting everyone to please answer the questions. The feedback poll is visible on your screen. Kiran sir, we can end the feedback poll. Thank you so much, Dr. Amrita ma'am, for facilitating this session.
You're welcome. Thank you all.
Thank you all the participants for patient listening. We'll conclude the session now. Thank you.